Okay, ladies and gentlemen, if we can get everyone back, please. Thank you. We're going to start session two in 2 minutes. 2 minutes. Thank you. So we get everyone into their seats, please. Thank you very much. Okay, ladies and gentlemen, just get everyone back. Thank you very much. Okay, so just a couple of housekeeping matters just before we start. This is the session two. So session one was framing the situation, framing the problem. Now we're going to look at urgent emergency care delivering high impact changes, and we're going to have an expert panel here in a moment that will be moderated by Dr. Rosa McNamara. If I can just ask you a couple of things. You'll notice here, Robin is working away here diligently and very in great detail, capturing what people have said and the stories that have been told. Particularly those of you on the other side, when we get to the break, if you get a chance to come over and have a look, please do so as well. Remember our hashtag in relation to social media, and let's see how we're getting on that as well. We're going to put up a slide now as well with a code, if we can put that up, please. And you're going to see, if you can see that code, this is a code that will allow you to contribute in relation to the networking and everything later on. So if you can actually scan that, it's a separate code to what you had earlier. And this is essentially giving you an opportunity to get a little bit more interactive. So it's a Mentimeter, scan the code, and you'll be able to get more involved in the conference as you go along as well. Okay, so if you can scan that, and if you're not sure about scanning it, find the youngest looking person on your row and get them to do it for you. Okay. Now, I'm delighted to welcome our expert panel here, and our panel members, as many of you've seen all and met already. Our moderator is going to be Dr. Rosa McNamara, who's the clinical lead for emergency medical program, and she will chair it. John Fitzmaurice is the integrated health manager in the HSE West and Northwest region. Heather Coetzee is the interim chief operations officer at the Mater Hospital Dublin. Catherine Murphy, who we met already, as you did meet Heather, is a patient and family representative. Professor Julian Redhard is the National Clinical Director of the NHS for Urgent Emergency Care. I also found out during the coffee break he works with Chelsea FC, and he's now my new best friend, and he has a stalker. Okay. Dr. Des Fitzgerald is emergency medicine consultant in Waterford, and Denise Roxburgh, the urgent emergency care lead, HSE Dublin and South East. I'd like to invite them all to the stage, and if I can invite Dr. Rosa McNamara to chair this panel discussion. Thank you very much.
That's great. Thanks, Emil. Okay, so just to reiterate, if you use Menti, what we're going to do is we have a few questions that we have accumulated through previous Patient Flow Academy events or questions that have come in already and that we are going to speak to initially. But as the questions come up, I would like if you would answer the questions in the audience as well, and that will help us to, I suppose, frame the conversation or maybe reframe the conversation that we're having, okay? So again, if you use the QR code, you should be able to interact with the questions. Okay. Right. So our first question is, what do you think is working well in your service in enhancing patient flow and patient experience? I might start with you, Des, because you spoke very nicely about this in Waterford very recently to me.
Um, well, I think we're quite fortunate in that we have, one of the two hospitals ourselves in Tullamore, which appear to have sort of cracked the difficult issue of overcrowding. But there's an awful lot of work that goes into it, and I think an awful lot of it is about teamwork and operational grip. Certainly, we've got an excellent management team that work very closely with us, and they are very, very hands-on, and very, very committed to, if you like, their mission of zero trolleys. And we haven't had any long waits for beds since COVID, which I think is pretty impressive and testament really to the management team that we have, and both hospital management and bed management. They've been terrific. They really, really have. Yeah.
Fantastic. And John, from your point of view, how would you see, or what do you see is working well? And I see the word cloud is growing very quickly. So thanks, everybody.
Yeah, I think look, we're taking I would say a broader whole system approach where I think certainly we're moving into a new era now of integrated structures and greater integration between the community and the hospital. And I think part of that is about increasing understanding of I suppose, making it everyone's business in terms of that the patient journey, that's the person. I suppose the neighbourhood concept was used this morning about a person that's coming from a community, coming from a home. The priority should be to focus on keeping that person at home, making that journey if they need to go in for an acute episode, that it's as short as possible and that it's as seamless as possible. But I suppose that's the key thing about broadening that responsibility, broadening that awareness, and I suppose accountability within that as well, in terms of being clear about who's accountable at every step of the journey for that person is really, really important.
And I'm not sure if you guys can see the word cloud, but certainly those themes of communication, teamwork, and collaboration are, to the fore in the cloud. So obviously within the room, we agree with you, Des. You're good. Can I ask you, Catherine, from your point of view, looking at it from through a different lens, what do you think worked well in your experience?
Yeah, and there's maybe one thing I didn't mention. When Dad got the diagnosis of dementia, it was during COVID, so two of us did an online course with the Alzheimer's Society of Ireland, just tangentially, but it meant there was time dedicated to figuring out how to care for him, how to speak for him, but also people talking about how to navigate the system. So in terms of that kind of improving his patient experience and flow, we were better able to figure out the system at that point. And when the integrated care teams kicked in, like, they were super, and things, dots joined up. But actually, us learning helped his experience. Yeah.
That's a really good point. That idea that I think you touched on as well, Julian, that you can find a way to navigate the system so that you can make those decisions to go to the right place for what you need at that time. I don't know if you want to comment any further on that.
Well, no, I think it comes down to those two things, which is one is that continuity of care and knowing that someone who knows your dad, so he knew what he wanted, rather than having to repeat the story over and over again, and then get people with different attitudes coming in, which may not share the relationship that he's had with your father and with with the family. So I think that continuity of care is really important to me, and then being able to gain that advice through that sort of person who's coordinating your care for you through that aspect, but they being able to gain advice from a sort of professional senior single point of access, so that they then understand how to navigate various parts of that system as well.
Absolutely. We might move on to the next question, which is, what are the key traits of effective teams to deliver improvement? And Heather, I know with your hat on in improvement that perhaps you would like to talk to this.
Sure. So I think the things that we have seen work really well in the Mater are, and I think the whole of healthcare is moving in this direction, is a more flattened hierarchy in terms of teams. I think we're getting better at engaging full teams in change processes. Like, improving patient flow is something we've tackled many times, and there's many people in this room who will have been part of the Mater's attempts across time to try to get improvement. And we get a bit, and it's difficult to maintain traction. I think the difference that is happening now is meeting teams where they are at. It's not about bringing people in and explaining the solutions. It's about going to teams, working with them, because every team member's experience is going to be different, and it was touched on before. I think part of the difficulty is that individual members maybe don't know what their role is within that process. So it takes more time. It involves real engagement, but I think teams where the whole team is engaged, I think clinical leadership is really important. The reality in healthcare is that consultants are viewed as head of teams in many ways. And as those power gradients are reduced, if we can get buy-in from both the full MDT and clinical leads, which is happening increasingly now, we have a much better chance of delivering a change if you can engage on that basis.
Absolutely. Just looking at what's coming in from the group, so thanks very much. This is excellent. We see some similar themes: shared vision, communication, leadership, respect, collaboration, listening. I think they're all, I suppose, speaking to the same point that like there has to be that ability to communicate across systems, silos, departments, healthcare facilities, anything that makes up the local or your community of healthcare is key.
I completely agree. And I think the other thing that works really well is where teams cross the boundaries. So, like, our biggest risk is always at the boundaries. It's at the boundaries of care, the boundaries of community and hospital, and having teams that actually work across the boundary, those makes those transitions much easier. It also means that those people understand both perspectives better. So I'd be really supportive of those type of teams leading the change that will impact this issue.
Okay. And Denise, did you want to come in there?
Yeah, I suppose with the development of the new regions, we can kind of see we now have this shared vision that Heather was talking about. And I suppose having a vision for the region of what, kind of going back to what Niamh's saying, the non-negotiables and what is expected, and kind of making patient flow everybody's business. And I think previously it was kind of working in silos. You had the discharge coordinator, you had the nurse and home support office, but actually getting everybody together and understanding the whole of the patient journey. You know, what struck me about Catherine's story was, you know, particularly in acute, we're all about trying to get people home as quickly as possible, you know, to try and hopefully reverse some frailty. But actually, where is the safety net for when they do go home? You know, where is the roadmap for people at home and what they're trying to do for the families? But yeah, and so I do agree with Heather in that.
Yeah, that's an interesting point. Like we are all, everyone's trying to do the right thing,
Yeah.
and we often are like, let's just get you out, and then that's somebody else's problem. But that's not the way we mean it. We mean, you know, it's bad for you to be here, so you should go somewhere else. But the somewhere else mightn't be any
Yeah.
better. In fact, it might be a worse option.
Because we all know
And
that
we lack that ability to know in the
Yeah.
system, I think.
we all know that acute hospitals are probably the worst place for patients who are old and frail and sick to be. Yes, they're acute phase, they need to be there, but as the kind of their length of stay is more protracted. But what that roadmap is then for families at home. So
Not to quote Brian Dolan, but you know, making sure that every moment is
Yeah.
value added for the person that's in that situation. Another point that's come up here in the probably third most common thing to write is around accountability. Do you want to tell us how you've tackled that in the NHS?
Yeah, no, I mean, it's interesting thoughts about how you do change and where that comes. And I think for me, if we take the hospital system and then expand that out, we do have a very strong system of the triumvirate, which is, and I would actually put that into four-person. I never know how that's called, quadranted or something. I don't know, whatever. But effectively having a boss doctor, a boss nurse, a boss manager, and a boss healthcare allied health professional makes a really powerful team for change. And added to that is culture. And culture is so important across all of our systems, and it goes across the interfaces because very often it's a different culture you're talking about across different interfaces, and how we change that for everybody. And that's why I talk about everyone left shifting together, because it can't just be one part. Culturally, everyone has to go, and how we get the triumvirate view of the world is actually really, really important, a powerful tool for change.
Absolutely. We might move on to the next question, which is a yes, no, maybe. Okay. So is there currently a whole system approach to patient flow? John, do you want to give us your hot take on that?
Yeah, I'd probably go in the somewhat category. I think we have a journey to go. I think in terms of that, there's certainly a lot of good work that has been done. There's certainly a lot of integrated work that's been done. But I think we we talk about, I suppose, culture has been mentioned in terms of, is there a collective kind of ownership of kind of what's required? I'm not sure. I think in terms of we still have probably our own individual silos. We still have our silos, which is natural. It's natural in a sense to a degree. So it's about trying to maybe come out of that to a degree and have the perspective and understand the perspective of, be it the acute hospital or be it the community nursing unit or the home support person that's working in the community. So I think there's certainly a lot of good work done, but I think we've a journey to go. And I think part of that is probably making that everybody's business. Now that sounds great in theory, but what does that mean? And I suppose it does relate to kind of, part of that is about creating that sense of the value in the work that you do, and the value of the work you do, be it at whatever level you do it, being able to demonstrate that. I think we're certainly, from a hospital perspective, we're far better at documenting the work that we do on a day-to-day basis. I think we're not as good at a community level at documenting things like the hospital avoidance measures, the work that goes on a day-to-day basis. And that's the value I think that we need to be able to talk about, to bring, and that's for staff, in terms of that creates a sense of pride, that creates that sense of belief in what you're doing. And I think there's a body of work we need to do there, because there's so much work happening in, I'm come from a community perspective primarily, but I think there's so much work happening at that level that we're not documenting effectively. But it's very hard then for staff to buy into that if we don't demonstrate that.
Yeah, I absolutely see what you mean. And it's hard to, I suppose, convince everyone in the system that they're part of the solution to improving flow. Des, do you have any perspectives on how you portray the Titanic?
We are quite siloed, and everyone else is the cause of our problems. It's the surgeons are doing what they're doing, and they won't come and see my patients, and the GPs are sending all the patients in that they shouldn't be sending in, and there's no beds, and that's bed management's problem. But that's not actually true, because I think we all need to take ownership and responsibility of the problems that are within our own gift to solve. Crowding in the emergency department isn't just caused by all of the patients, the 10 or 12 patients who may be there waiting for a bed. But it's easy for us to throw our hands up and say, oh, well, I can't do anything because there's 12 patients waiting for a bed, where we know that 75% of the people who come through the door today are going to go home. So, that's in my gift to solve, is to see them as quickly as I can. So that's where, our focus for a long time has been on the non-admitted patients. So there's no point in making our own crowding by leaving these people to wait for 24 hours before they're seen. We can see them ourselves quickly, so why should we not do that? In regards to the sort of the whole system side, I do think that once we've gotten our own house in order, for want of a better word or better phrase, I think we can then go to places where we're afraid to go. Be that going to the surgeons or going to the GPs or whatever it might be, or asking them to come to us, because as somebody said earlier on, you're speaking a common language. You know what they want, and they know what you want, and also you're able to explain, this is what I can do and this is what I cannot do. And I think that's really important, that sort of communication between teams, not just within a team, but between teams, and sort of a degree of trust as well. That that if I say I can deliver on this, then I have to live up to that, and I have to be able to deliver on it. If hospital management say that they're going to do something for me and they deliver, then I know that I can trust them. They will want something in return, and that's fine. That's how it should be.
So, if you can't see, just have a quick look. But the majority of the room have voted no, and I'm not surprised. That's why we're all here, because we're all trying to find a way through this, because we all feel like it's not working right now. So,
but it's the invisible patient flow that we don't see, because historically patient flow, you think about it, it's a hospital issue, it's a hospital problem. There's patient flow departments, bed management departments in hospitals, but it's the invisible patient flow, and trying to get that message out that it's the community OT that has gone in to see somebody twice a week, or the community physio that has prevented them going into hospital, to prevent them then becoming somebody in the emergency department that's overcrowded. So I think we do work in silos, but hopefully by coming together we can actually see that it is everybody's responsibility, from the community paramedic right up to the consultant to even the GP secretary, to be able to get people in a timely manner. So
absolutely. I'll move on to the next question. What do you think would be the 3 high impact changes to improve patient experience in urgent and emergency care? So pop up what you think that answer is, and I'm going to ask you, Catherine, what do you think from that patient point of view? Even pick one.
Yeah. I guess improving patient experience in emergency care, I'd probably go back to something that you spoke of earlier. It's that first piece of being told you're not dying. When you're going in with mom or dad, it's that first piece. knowing you're not dying, and then the next question is, are you being admitted or are you not being admitted? Is where we're going in terms of their worries for what they're doing. For us, then there are, yeah, it's not high impact, but it's just how you're minding them and getting them a sandwich and getting them a cup of tea.
Well, I suppose it's high impact for the person who's on
Yeah.
the receiving end of that. So absolutely would take that, you know. Julian, from your kind of bird's eye view of a complex system, what would you do if you could wave a magic wand?
Oh my goodness! I mean, that is a sort of $1 million question: is where would you start? I mean, I think we have to concentrate on pre-hospital, and remember that pre-hospital is the same side as a coin as discharge. They're the same things we're talking about. It's not different. So when I say about pre-hospital, it's both ends of the system that we need to get right, and that's partly to provide better care in the front end systems, and then improved care at the back end. Now, how do we do that is quite a big shift in culture and a big shift in lots of different services we've all talked about. But I suppose it's also that interaction between social care and physical care that we're talking about. And how do we get that bit right? Because I just don't think at the moment we're all getting it right. So we're all then being in silo between social care and physical care. And patients go around in a yo-yo around this and they can't get the right care for themselves. So I'm very interested in how do we go into the future of funding between social care and physical care. But that's a big policy change. I'm not suggesting any policies here, but that's where I think we need to really look quite closely. And you'll find incentives for that will change things. It will change the way that we view discharge, the way we view pre-hospital care, if we get those incentives in the right place.
And John, I guess from your point of view in the community again, you know, if you looking from your angle, you know, what are the three things that you would do?
I think again, if we bring it back to its most basic level, I suppose it's trying to meet the person on their terms in sense of, you know, so where they've in a sense, look, there's a basic communication, a basic education side. It's amazing. I talk specifically about older people, and you know, it's amazing how disempowered they can become when they go into an acute hospital, in a sense that they, you know, and how vulnerable they become all of a sudden, and it's and dependent on a level, and it's about trying to get that back to where try to put them in control, and maybe family and community in control, in the sense of you know the options that are there outside of the ED. You know, thankfully there's been an awful lot of investment in services like, you know, ICPOP and enhancing community care. A lot of, but there's a danger that you know, we've seen that in the last number of months where something has to give. It's often the community that will give because the hospital has to function. We get that. So to get that balance in terms of between that community investment and that hospital investment, and trying to that shift left, we've got to stick with it because pressures will come on, economies will change, pressures will come on, but we've got to be very true to that in terms of trying to maintain that focus. And that's not going to be easy. But I think keeping the person at the very basic level about what's in their best interests, how can they be empowered, how can, you know, and that's again going back to the person, the family, the community, you know, always staying true to that focus, because that's where they come from, that's where they'll go back to.
Yeah. I see from the audience that we have communication being one of the key words that has come up in the word cloud. And I think that's a fair point, because a lot of the silos or a lot of the isolated working spaces are to do with a lack of communication or gaps, or just no ability to even know how to communicate with groups. So probably is a key bit of like, if you were going to hack the system in the morning, that we would all just talk to each other. If you think about it, you know, in emergency medicine, we go on about high performing teams. Julian and I once had the British rowing team showing us how to run our emergency department. I think we might have had Formula One guys teaching us how to pit stop trauma. And I suppose, you know, with that, the key thing I always took out of it was we actually all were in the same room speaking to each other. So, you know, the surgeon was there with us, the interventional radiologist was there with us. So actually, there wasn't a silo, there wasn't a wall, there wasn't a phone call. We were all standing there together going, what do we do? Okay, we'll do that. And I think it's the same principle probably, is that idea that you can just talk to people. You don't have to run through a rigmarole of steps, online forms or whatever it is to get to the answer that you need. And I see health promotion, empathy, admission avoidance, teamwork, discharge planning, and access diagnostics all really prominent in this word cloud. And I think all are potential solutions to many of the problems that we're seeing. I'm going to move on to the next question, which is, what is the effect on staff of persistent challenges in the delivery of urgent and emergency care? I'm going to deliberately not ask the two emergency people on Heather, do you want to take this one?
I mean, I think anybody who works in the system is seeing the impact of this at the moment, also within the broader context of challenges within the health service. And there's the word burnout. So people who go into healthcare, I'm a firm believer, people at baseline are good. 99% of those people are there to positively impact people, the healthcare system, but at its basis, people, and it becomes incredibly difficult when you don't feel you can do your job well, or when you feel that the system within which you're working places people at risk. So I think the burnout is very evident. I think one of the a ongoing consequence or a downline consequence of that is disengagement. And then it becomes even more difficult to implement the changes that you want to implement to try and improve it. If you've lost people, if they're beyond being able to engage, if they're disillusioned, that is very difficult. And ultimately, you'll lose them from the service. And every time somebody leaves the service, you're leaving somebody who has knowledge of the system, who has learning, who has good ideas. So I think that's the negative side of the effect on staff. I think there is if you can catch people before they're burning out, if you can catch people, and there's a lot of new entrants into the system who will bring fresh ideas. Those challenges will be the spark that instigates people to try something different. I think that is our challenge, because the challenge is not going to go away overnight. We do need to try and catch people before they burn out, get the good ideas and try and implement them. But I'm absolutely not minimizing the fact that people working within the system, it's rare that I've seen people as concerned about what's going to happen, particularly now as we come up to the end of the year. I think that has to also be balanced with some of the metrics that have been presented, where it is far from perfect. It is better than it was a year ago. Not for everybody and not good enough, but there is a journey here, and it is headed in the right direction. It's about trying to engage people.
I suppose that idea of moral injury, it comes through very strongly in the feedback from the group, and how that feeds into burnout and performance and solution finding.
Yeah.
It is key. Did you want to come in maybe from your perspective? I know you've worked across many different spaces and times at this stage.
Yeah, if I take off my ED nurse hat, and yeah, like burnout does, absolutely, it does run, and we are coming in, and I think every year we hear the same rhetoric. We're coming into winter. It's going to be the worst winter we've ever had, and every year seems to be the worst winter we ever have. We have, obviously we have the workforce planning now. We have, caps on filling posts, but yes, there's all of the challenges, but I think for us, it's about empowering the staff who are working in these areas. And I suppose that's what today is about, because you know what the difficulties are, you know what the challenges are, and it's how can we empower you to kind of put your head up a little bit and make those kind of hacks or areas to continue giving good patient care, because despite the burnout, the low morale, patient care is still the forefront, and it's still very good in a lot of the areas. I don't think any of the areas that I went into that has low morale, they're always talking about the patient and making sure the patient is still fine. So it's about then what we can do to try and assist those challenges. I know a lot of people do say they're starting to do huddles down in ED. They meet every 2 to 3 hours with the consultants to see kind of where we are at the minute and how we can kind of continue on. But yeah.
And I think, sorry to come back in, but just a word that was mentioned across a couple of the questions, kindness comes up a lot, and I think that's something that persists. We see staff who are like working additional shifts. They're working in an environment that's incredibly challenging. But often the care that that is received from patients, and I think that it came through in your story, is that kindness persists, like that intent remains. It's just very difficult. We need to keep that alive while we improve the structures around it.
Absolutely. The next question is actually, I suppose, a tough one. But what are the fundamental design flaws currently in the delivery of urgent and emergency care? Des, do you want to kick us off again?
Only people
No,
want to
no,
know.
no,
Done
no,
something bad
no
before.
one says no.
You're writing a line.
Yeah. I think for a long time, unfortunately, the structure of how care is delivered or has been delivered in Ireland, certainly over the last, well, since I've been here in the last 10 or 11 years, has pitted the acute against community because of the structure. And I don't think that that has served either particularly well. Whilst, you know, we will try to go to community, or community may try to come to us for us to try and solve specific individual case based problems, there still is that tension between community and the acutes, and I don't think that's right. I think now with the RHA structure, I would hope that that'll break down that barrier and there'll be a good bit more cooperative work between us, all of us. But I think one way to get through that, I think, is something that has come up in quite a few of the previous questions that I've been thinking about is, even for improving the patient journey and then helping solve some of these design flaws is sometimes it's signposting. When patients come to us in the emergency department, all we do is actually for some of them we'll solve their clinical problem, but a lot of it is actually just telling people where to go to access the care that they needed. And I think if patients knew that before they ever came to the emergency department, or the GP was aware of how to access this care or where somebody would be best to go, I think that would probably serve patients better, and I think their experience actually in turn would be better because they would know that they were going to the emergency department and that their problem might not actually be solved today. So I think, breaking down that barrier, I think, between acutes and community, I think.
And I think, Julian, you spoke a little bit about this earlier, but, on that point.
Yeah, I think, if I take the UK example, the NHS was designed in 1940, whatever it was, with Bevan, and I think that medicine has moved on. The population has changed. What we can do for patients has moved on, but the delivery of healthcare has lagged behind that. And what we need to do is catch up exactly where we're going. So looking at those innovations, and if you think about 10 years from now, what that could look like in terms of AI investigations, ability to really precision care individual patients, we have to start moving in those directions so we're ready for those revolutions. We'll become a much more digitally enabled population. And it will be unusual for someone who won't know how to use a computer, won't know how to book appointments. We've got rid of faxes. I think there's still one area that has faxes. But eventually we need to get rid of letters because letters aren't really a modern way of doing things.
Yeah.
So we have to think for the future constantly.
And just looking at the responses from the audience, lack of diagnostics, space, hospital-centric care, all very clear. Just as you say, you look to 10, 20 years into the future, will we all deliver all our hospital care in a hospital between the four walls of a hospital? Probably not. That shift will have to occur, and it won't be community having to step up, it'll be us having to step out. That integration is true. And it's at the moment we're at the beginning of that journey, but that idea that, emergency medicine is in that pre-hospital space, but we're also in that post-hospital space, that everybody is working in a much more integrated fashion. I'm trying to think, there's infrastructure, lots around access to care and use of data, all, I think, really, clear points that, highlight what exactly isn't really working in urgent and emergency care. And I might add that there still is kind of one door
Yeah.
at the moment. So, at 2 o'clock in the morning, if something's wrong, there's one clear place that you can go. You used to talk about poor branding in the NHS and that A&E had turned into anything and everything at one point. Um,
But, I mean, and it has. I mean, but that's why we've got to start thinking of how you separate emergency from urgent, because a lot of this care actually, as you talk about signposting, is urgent care. It's not emergency care where you've got patients who really need the skills of the emergency department and that whole multidisciplinary approach. So we've got to get it right so those patients can receive that care and the urgent care community can get the right care for them, which is not over medicalising. And it's being able to talk to a patient on a level. Anyone who works in an A&E, trying to talk to a patient who has complex urgent care needs when you're standing over them and they're on a trolley just doesn't work. And we've got to get better at the environment, the infrastructure that we're using for those patients as well.
Yeah, and I also think that sort of big pot of emergency and urgent, and then some what we might consider not urgent, all sitting out in the waiting room. This reminds me of sort of looking out of the majors area, and this is the waiting room here, and everyone's staring at me, and very few are smiling, someone to kill me, and they're all wondering why I'm not making eye contact with any of them. That like I don't know who amongst you is actually really, really unwell, and so that's why we have triage and that to try and help. But that's because when you've got all of everybody just all kind of mucked in together, the risk for those who are very, very sick but kind of undifferentiated grows and grows and grows. So that's why we worry that the care for an individual patient or all patients is probably less by having so many people, if you like, in the wrong place. And that's again why the signposting, and signposting is not just about making my life easier because we're not having so many patients come into the emergency department. We still have to care for everybody who comes, and the patients who need to be admitted will need to be admitted. That number won't change, but it's just in terms of that, if you like, that urgent care, getting people to a better environment for them to be seen to have those conversations rather than 30 seconds with me, if that makes sense.
Absolutely.
I think one of the things we need to look at as well in terms of that, you talk about there's often only one door, maybe late in the evening or at night, and I think we've got to look at how we can increase capacity, particularly in community, and that's a challenge for community. But that's a challenge of resourcing, obviously. But we've got to look at that around maximising, our diagnostic capacity across communities in terms of so that our services are open beyond 5 o'clock into the evenings and into the weekend, because that takes pressure off everyone going in through the one door. So that's certainly something we've got to look. Because we have a lot of infrastructure now. We have a lot of good infrastructure in our communities that's underutilized. And I think that's something that we've got to look at about how can we maximise the potential within that.
Absolutely. I'll move on to the next question. What, in your view, is the discharge stage of the patient journey rated the lowest of all stages of care in the HSE inpatient survey? And Catherine, I might ask you because this really is a thing I took out of your talk today, is like that interface, and there's 1,000 things that probably could have been done better.
Yeah, and I think it is that piece that we keep coming back to about the integration. And I don't know if there is a place that all of those people talk to each other and understand each part. So for us, it's a lot about the healthcare assistants. It's a lot about the discharge coordinator and conversations to be had with us, because we were in a position where we were also the good people trying to do the right thing with what we had. But we talk about digital transformation. There isn't stuff on the website. Like, there is nothing you can read in preparation. That's just the website stuff. I was saying, even I was doubting myself, and we kept lots of notebooks, and the family WhatsApp was a great source of information going, yeah, that happened that day. Yeah, that's who we contacted next. And then I went online to go, well, who are the people? What is the proper name of that unit again? And you just can't find it. So in terms of just being able to know if somebody's coming home, well, what are the pieces that are available to us? And of course, I would say also, certainly for my dad, he was a performer. So if they gave a sniff that he could come home, he was up, but he could suddenly walk and do everything, and like he would put in the big effort to get himself home, because he wanted to be there. But for us navigating the systems, there isn't enough of a support there for us as a family. So we're talking about patient flow, but also the family flow of how we navigate the appointments, like a set of simple things like how many appointments does dad have? What are the preconditions for all of these? Who has to be confirmed beforehand? Who's bringing, is there a urine sample? What does he have to bring with them? Like all of that piece that is somewhere on all of the computers, but it's actually nowhere that any one person can see. It's kind of a very long-winded piece to that.
Not at all. I think it's very relevant. And then who referees it when there are two appointments on the same day, as you mentioned, or
Yeah.
when there are drugs that are probably not complementary to each other, and how do you find out who that person is?
Yeah. So it's the pharmacy is really important. The relationship with the pharmacy, and having those conversations, and for us as a family, we were all on the one page. If we weren't, this would have been 100 times more difficult in terms of navigating those pieces. And you're dealing with everything from the triple bypass surgeon or consultant wants to see him, and also he has a toenail appointment, and like both of these things are really important, but you're trying to move around the city in wheelchair spaces and get to all of these things and get into car parks. I just have to say about paying for the car parks. Like, yeah, you're doing all of that.
Did you want to come in here as well?
Only because I think it raises the point about how we're training doctors of the future and the impact of generalists against specialists, and we're going down the left toenail specialist, to use your analogy. And the reality is that what we need is people who are generalists, who can actually look at a patient as a whole and not just think about their heart or about their gastro, and actually bring it all together. And there should be a sort of, you shouldn't necessarily have to go and see 5 different specialities unless you're really a complex patient who really needs those type of things. So we've got to think into the future about how we train.
I think it speaks back to how acutes in the community, like what you were saying, aren't working as one. We were 2 separate entities for so long. And I suppose the vision and the hope is that we'll come as one now because there's one structure. But like I would do a lot of discharge planning with a lot of the hospitals I work with. And actually your story struck me a lot because I'd be like, well, why are they still in the hospital? Why can't they go home? But actually they might be able to go home because they haven't got a bed downstairs. And that would never even have occurred to me previously. But also, where's the handover? So where's the handover from the acute into the community? Where, do the acute staff know who to contact because maybe we might need nursing home in 6 to 8 months? Or is it just that they're discharged, they're gone, see you later? And then they start again from day 0 again back in ED in 4 weeks' time. So I think there's a lot that we can do with our community partners and kind of planning the discharge a lot better, and looking into those processes, because definitely I think it's like the finality of their acute, right? They're gone now. It's on to the next person, but actually it's about making sure the journey is from home to hospital to home.
Yeah. And just to come back in one point, so I was chatting a lot in work about I was coming to do this talk, and everybody's telling you make sure you say this. Okay, so I'm carrying some of that at the moment. And one of the girls talked to me about, because it's you've got all the different appointments going on, and you're really hoping the public health nurse will ring you. And so even when you're back in work, you're on a bit of an edge because you're saying you're in a meeting or something. You're saying, no, that could be somebody. It's an unknown number because the public health nurse often won't ring from a known number, so you don't know who it is. But it could be any one of the people. The OT might be deciding to call today, so you're constantly on an edge, saying, "I need to go to do this because this could be somebody important. I don't know who they are or who's ringing me at the moment." To try to manage those. That's Linda. Work. Make sure to say that.
Shout out to Linda. I think overwhelmingly we see that communication and planning are what we see as the big gap. So, I mean, that's food for thought for all of us as we're, when we're leaving today. How are we going to improve those bits? How are we going to provide much more comprehensive planning, or, I suppose even how that gap is managed between when community are able to see somebody, or as we say, pick somebody up, and when their episode of care in the hospital is completed, because those gaps are, they can be lethal.
I think just a couple of things that I think underpin some of the conversations. So we've spoken a lot about signposting and communication. I think the lack of digitalization of information, even aside from the advances from a medical perspective, but just in terms of how people own their own information and how that is communicated between different settings within the health service, is a key challenge for us. It's something we do really poorly at the moment. And the idea of a single source of truth, I mean, we've tried to map the services that are available around the Mater. We can do that now, but in a week it's out of date. And often the members of the team that we rely on most heavily to deal with the most complex part of the patient's journey, which is the end. It's not the beginning when they come in and everybody's in the same room focusing, are the most junior and often NCHDs who are rotating. And we expect people to know what is available without a telephone line or a single point that we can ring. We need to find a way where people can access what is available in different areas, because there is no standardization either. Things vary area to area. So I think sharing that information in a more coherent way would be a big enabler. And the other piece that we are not acknowledging is that, but I think it was mentioned in terms of that things have changed. If you take the Mater Hospital, 11% of the people who come in who need discharge are homeless. Yeah. It's underrepresented in the data that we have, and it provides a social complexity for discharge that we are not currently set up to address. I think that is something that we're going to have to work on if we're going to crack discharge.
Absolutely. Now we are running out of time, and I can see Barry itching to take the mic off me. So I'd like to thank our panelists very much for your contributions and your interaction, and to you as well for your contribution.
So just make sure everyone is safe getting off the stage. I was struck by something that Heather said. She said that the gap is dangerous, and I was looking behind her. It is very, very dangerous. But can I just again, first of all, thank Dr. Rose McNamara. That was excellently. We got so much out of people. To John Fitzmaurice, to Heather Cudsey, Catherine Murphy, Professor Julian Redhead, Dr. Des Fitzgerald, who I think took a lot of heavy lifting there in terms of what are the solutions, and Denise Roxburgh as well. I think it was really interesting just listening to Denise. Just saying frankly, actually, there was something I never thought of. That's that ability to be open and say, well, actually, that's a new perspective. That's something we should look at. That's something we should consider. We are coming up to lunch. Just a couple of things just to say to you at this point. We have till 1:20 for lunch. If you get a chance, will you please come over and have a look at what Robin is. This is fascinating, and I think it'll jog your memories. And it's quite interesting because people learn in different ways. Some people remember stories, but a lot of people are quite visual, and I think you'll be very impressed with what you've seen there as well. Just a couple of other things as well in terms of housekeeping. We're going to aim to get back for 1:20 again, so you've got approximately an hour for lunch. Again, if you're using social media, keep an eye on the hashtag, see how we're getting on in terms of what you put up and what you consider as well. This has been the second session, urgent and emergency care. The third session is going to be on the front line. I don't think there's a person in the room who won't have an interest or an insight into that particular area. Can I thank everyone so far for their contributions, for their time and for their stories. And guys, we will see you at 1:20. Thank you very much. The heart is a blue, shoots up through the stony ground. There's no room, no space to rent in this town.